goiter. It is a diffuse enlargement of thyroid. Diffuse enlargement is all over. The thyroid gland is enlarged. Why? There is a formation of thyroid nodule. Sometimes you will see the colloid deposition, and sometimes the hyperfunctions of the thyroid follicles, making it hypertrophy of the cells, and as a result the thyroid gland is enlarged. But most of the time the goiter, there is a diffuse enlargement of the thyroid due to iodine deficiency and also colloid deposition. Colloid is a materials, okay, collagenous type materials deposition. So, okay, we don't need to put the one number. Now, diffuse enlargement of the thyroid gland causes number one, usually colloid goiter. These are simple and non-toxic. And another one is iodine deficiency. One is a colloid deposition, another is iodine deficiency. For colloid goiter, usually has no clinical significance other than the focal growth of the diffuse mass. That means if this is the neck, then there is a simply the thyroid gland has a nodule. Multiple nodule and not hyperfunctioning, because this is not the thyroid gland. This is not the thyroid follicle enlargement. It is a colloid deposition. Okay? Then what happened? There will be diffuse enlargement of the thyroid gland that is in front of the neck. So this is the goiter. Usually has no clinical significance, means it does not bothers the lifestyle. It's not going to cause the hyperfunctions, not going to cause the hypofunction. So only the cosmetic disorder, otherwise the life is fine. Not palpable until its volume has doubled. So normally thyroid gland is not palpable until its volume gets double and grows slowly over years or decades. That means the colloid type no clinical significance. Focal growth, diffuse enlargement, not palpable until the volume is double. Slow growth, may become nodular with or without necrotic area as it ages. Okay, so this is the clinical criteria of colloid type. And iodine deficiency, the gland enlarges to meet the demands of the basal metabolic rate. So iodine deficiency goiter, it is usually the over-functioning of the gland to produce the hormone to meet up the basal metabolic rate. Okay. Now I will go over the sonographic appearance. You got it?
Mm-hmm.
Sonographic appearance of goiter. When there is a multinodular. When there is a multinodular type, you will see the large symmetric or asymmetric glands with diffuse in homogeneous or multiple discrete nodule. Interspersed throughout an otherwise normal appearing gland. Large symmetric or asymmetric glands means equally on both sides or non-equally, with diffuse inhomogeneous means heterogeneous, or multiple discrete nodule means multiple discrete separated isolated nodule interspersed throughout an otherwise normal appearing gland. That means if I do the drawings for you, you'll see the inhomogeneous, isolated mass is a hypoechoic to little brighter, interspersed over the normal appearing thyroid tissue. So now tell me, if the thyroid gland has a multiple nodule like that, what do you think? Thyroid gland will be enlarged or not?
Mm-hmm.
Yes. That's why you will see lot of palpable mass within the thyroid gland in front of the neck. And number 2, cystic area from focal necrosis and punctate calcifications are not unusual. If you see the cystic area means anechoic area, when you see the anechoic area, it is usually due to necrosis. Okay, this is necrosis. Necrosis means cellular death. So now you can see the cystic areas from focal necrosis. And punctate calcifications. Okay, so these are the sono appearance of the multinodular goiter. And write down, usually it is benign. It is usually benign. The goiter is benign, but if there is a rapid growth or hoarseness of the voice, so it is a sign of malignancy. Okay, so it will be instructed, patient will be instructed that you need to observe it. If you feel there's a growth is too much and is painful and is warm over there and voice is getting hoarse. What is hoarseness of the voice? Like, hello, how are you? So this voice is changed, hoarseness of the voice. So now I will talk about the adenoma. So adenoma is a benign tumor from the follicle of the thyroid gland. That is the adenoma. Adenoma of the thyroid gland. This is the benign neoplastic growth. That means number one, you can say, or just definition, it's a benign neoplastic growth usually contained within a capsule. So usually it grows from the follicular type are the most common. Slow growing or slow growth. That's why doctors doesn't care. Okay, keep it. We will follow. remain dormant for years. One 5 centimeter to 1 centimeter size, when they come up, they can be palpable. That means when they get palpable, the size is at least 0.5 to 1 centimeter. It is typically asymptomatic. Typically asymptomatic. Sonographic appearance greatly varies. It could be cystic to solid, it is very important. Lot of times you will say this is hypoechoic to anechoic, and you can feel, you can get nervous, is it a cyst or a solid tumor? My advice, click the color. If you see the color is inside, then there is a tissue inside. So it is a solid mass, hypoechoic to anechoic in nature. But if it is a cystic, it must give you certain criteria. Enhancement, anechoic is refraction, thin smooth wall. So it could be cystic to solid. Most common appearance is solitary. Most commonly it is solitary, well circumscribed, oval or circular. Mass. And number 3, variable size and echogenicity. Sizes and echogenicity. So size could be different, and echogenicities are greatly variable. Someone could be anechoic, hypoechoic, isoechoic, and hyperechoic. Various types of echogenicities you will see. So normally, if I draw the diagrams, so this is thyroid gland. You might see a nice it's better to draw with the different color. Usually it is homogeneous. You might see singular you might see more. Okay, echogenicity, you will see there is a variation of echogenicity too. Okay, so this is the nodule. We call it adenoma. And adenoma comes from the follicular cells. What is follicular cells? So this is a follicle. Thyroid follicle is the functional unit. It has a follicular cells. We call it acinar cell, just like a pancreas. And this growth comes from these follicular cells. So follicular cells has a growth. And it gradually gets bigger, that is adenoma. Because it must need a cell to grow. So what are the cells inside the thyroid gland? Either follicular cells or parathyroid cells, that is producing the calcitonin. Sorry, parafollicular cells, or there is a parathyroid. So these are the cells. And this adenoma comes from these follicular cells. So this is follicular cells. Okay, this adenoma is this one. Okay, so now we'll talk about the malignancy. Malignancy means cancer. It is a discrete nodule, means isolated discrete nodule. And usually this nodule is painful, firm, and is fixed, and that nodule is warm. Okay, and patient will give the history. Oh, it's growing faster. It's a discrete nodule. Mostly patient complains of an asymptomatic nodule. Mostly